So the first speaker for today is Dr. Nitin Sharma. He's a head and neck cancer surgeon who is currently working at HCG Cancer Center, Ahmedabad.
Good morning, everyone. So today we will be discussing applied anatomy of larynx and hypopharynx. So larynx has three roles to play in our body. First one is protection of lower airways, then respiration and phonation. But according to Negus, he was very famous British surgeon. He did a lot of work in 1930s on larynx. So he says, look at the point number 3 and 6. So bichir lungfish. This animal has got first primitive larynx, and the vertebrates are who were the first one to use larynx as a flutter valve. So according to Negus, this protection of lower airway is much important function than phonation. So embryology of larynx. So I expect you to look at this point only. Larynx developed from 3rd, 4th and 6th pharyngeal arch. We have three segments of larynx. One is supraglottis, glottis and subglottis, and supraglottis and glottis has further division. First we take a look about supraglottis. Supraglottis has got independent blood supply. This area is rich in lymphatic channels, and that is why we get more nodes at the time of presentation. This area has got bilateral lymphatic drainage. And supraglottis is derived from buccopharyngeal primordium, that is for 3rd and 4th arch. It is single midline structure. Embryonic fusion line passes through the ventricle, and this is the basis of why Alonso in 1939 proposed horizontal supraglottic laryngectomy. He respected the line of embryonic fusion, and his line of excision passed through ventricle. So this is supraglottis. Glottis and subglottis, they are derived from two lateral furrows of tracheobronchial primordium which fuses in midline. So these are unilateral structures, not like supraglottis. Lymphatics drain unilaterally. That's why we have unilateral nodes. Glottis sparse in lymphatics. That is why we rarely gets the node at the time of presentation. So now you can see glottis, supraglottis and subglottis are three distinct structures. They have different origin, they have different lymphatic supply, lymphatic drainage, and that is why we have divided them into larynx into three segments. Now spaces of larynx. So first pre-epiglottic space, of course name given by Boyer. So the boundaries are, boundaries are superiorly hyoepiglottic ligament, this one, anterior thyroid membrane and thyroid cartilage, inferiorly thyroepiglottic ligament, and posterior boundary is epiglottis. This pre-epiglottic space contains fat and areolar tissue. So in 2008, Peretti and his group proposed a classification of endoscopic supraglottis laryngectomy. In their classification, they have proposed 7 types. And out of 7, type 1 and type 2A don't involve excision of pre-epiglottic space, but type 2B and 3 involves excision of partial and complete excision of pre-epiglottic space. So you can see how this space is important. Entire classification was around this. So assessment of this area is very much important. Now, we all know pre and paraglottic space are in continuation. This is work by Kimonori Sato in 1993, nice paper. Now, pre-paraglottic space of Tucker, of course name given by Tucker. So, boundaries are lateral boundaries, thyroid cartilage, superior boundary is this quadrangular membrane, inferior boundary conus elasticus, and posterior boundary is pyriform sinus. So this paraglottic space is like crossroad. It has got lot of communications all around. As we saw, it is communicated with pre-epiglottic space superior medially. It has got communication with deep neck spaces through foramina from which superior laryngeal artery and nerves comes down to the paraglottic space. It is in close contact with this thyroarytenoid muscle, and posteriorly there is very less area of resistance between pyriform sinus and paraglottic space. So disease from paraglottic space can spread to anywhere. And furthermore, this paraglottic space is divided into two by line passing through superior aspect of true vocal cords. So we have two parts, superior paraglottic space and inferior paraglottic space. Whenever disease involves inferior paraglottic space, there is reduction in vocal cord and arytenoid mobility. There is upstaging. Stage 2 becomes stage 3. Now, again this inferior paraglottic space is divided into two in sagittal plane by line passing through anterior process of arytenoid. So we have again two inferior paraglottic space. One is inferior paraglottic space anterior and another is inferior paraglottic space posterior. So whenever disease involves inferior paraglottic space posterior, transoral laser microsurgeries are contraindicated. In those cases, you will have to do open horizontal partial laryngectomy type 2 or type 3. So this part is very much important. So now we understand this pre-epiglottic space and paraglottic space are like crossroads. चौराहा जैसा है, यहाँ से disease कहीं भी जा सकती है. So that is why there is upstaging and that is why these spaces are very much important. Now vocal cords. So this is the structure of vocal cord. Here is epithelium. Epithelium here is squamous type. Then comes the basement membrane. Basement membrane has got anchoring fibers and the number of anchoring fibers are genetically determined. So and they are inversely proportional to the chances of developing vocal nodule. Then comes the lamina propria. It has got three layers. The superficial layer of lamina propria is called Rinke's space. So this is very vital for phonation because this offers least resistance to vibration. Then there is intermediate layer of lamina propria which thickens anteriorly and posteriorly. Those structures are called macula flava. Then comes deeper layer which is made of principally of collagen. And these two layers, intermediate lamina propria and deep lamina propria, jointly forms vocal ligament. And one more thing, these two layers has got macrophages, myofibroblast and fibroblast. So these cells are vital for healing. Now then comes vocalis muscle. The vocalis muscle, the fibers of vocalis muscle runs in the parallel direction to vocal process, and the thickened part of vocalis muscle is called thyroarytenoid. So this is thyroarytenoid, which is in close conjunction in paraglottic space and very important for mobility. Now European Union of Laryngology divided chordectomy into different classifications. They have eight types, and let's see one by one. Type 1 is subepithelial, type 2 subligamental, type 3 transmuscular, and type 4 complete chordectomy. So in each type they take out one more anatomic unit. So that is how this anatomy is considered in this classification, and it has got bearing upon the vocal outcome as well. So whenever we excise anything above the vocal ligament, the healing is good. Whenever we take vocal ligament within our excision, the vocal outcome is worse. Now anterior commissure. Anterior commissure is most debated topic in entire larynx. So anterior commissure, it is not a point structure, but it is three-dimensional structure. So its anterior boundary, anterior wall, ventrally formed by intermediate lamina of thyroid cartilage. Then dorsally it is formed by three-layer insertion of vocal cords, Broyles ligament and conus elasticus. Now, the lateral boundary of anterior commissure is formed by lateral margins of intermediate lamina of thyroid cartilage. And posteriorly, in sagittal plane, the posterior boundaries are at the supraglottis. At the supraglottic level, epiglottis, the inferior most part of the epiglottis, form the posterior boundary. At glottic level, macula flava forms the posterior boundary, and at subglottic level, thyroid cartilage forms the posterior boundary. So this is very complex structure of anterior commissure, and why anterior commissure is so much important. So spread of the disease from the anterior commissure is very interesting. So there are three pathways. The most common one is, since Boyle's ligament acts as a barrier, usually disease goes down towards subglottis. But the interesting phenomena is at times disease directly perforates through the thyroid cartilage, because the inner perichondrium of thyroid cartilage is lacking just caudal to Boyle's ligament, and there are loose area of the blood vessels there, and the glottis is in very close contact with the thyroid cartilage. That area is called as Gourier's plane 0 or Brigandi's space X. Through this space, the disease in the anterior commissure sometimes directly perforate through thyroid cartilage, and stage 1 becomes stage 4. And that is the reason this entire anterior commissure is very interesting area, and that is the reason we have so many papers over this anterior commissure. Now, anatomy and robotics. So this is the era of robotics. In robotic surgery, we use following anatomical landmarks: median glossoepiglottic fold, pharyngo-epiglottic fold, greater cornu-of-hyoid bone, and paraglottic space. Among the vascular structures, superior laryngeal artery is important, superior thyroid artery, dorsal branch of lingual artery, and among neural structures, internal branch of superior laryngeal nerve. These structures are very much important when we talk about robotics. Now look at this picture. This is epiglottis. This is median glossoepiglottic fold. This is superior branch of superior laryngeal artery. This is hyoid bone. So you will get closer look in this picture. This is hyoid bone. This is superior laryngeal artery. This is internal branch of superior laryngeal nerve. So why superior laryngeal artery is so important while we talk about robotics? So first take a look of its anatomy. Superior laryngeal artery enters via thyrohyoid membrane from a foramen, and through that foramen paraglottic space communicates with deep neck spaces. So it has got 5 branches, and we can identify the superior laryngeal artery anterior and inferior to greater cornu of hyoid bone. So at times 5 to 15% there is aberrant superior laryngeal artery that comes from posterior portion of thyroid lamina, but branching pattern remains the same. So the identification and ligation of superior laryngeal artery is vital for all robotic procedures, because the most common complication for any robotic surgery is hemorrhage due to superior laryngeal artery. That is why superior laryngeal artery is very much important. Then inferior branch of superior laryngeal nerve. This nerve also enters along the superior laryngeal artery, innervates the mucosa of surface of larynx and hypopharynx, supplies interarytenoid muscle. It has got 3 divisions, and this is important for glottic closure, cough reflex, and protection from aspiration. So you can understand how important to preserve this nerve. Now, superior laryngeal artery, superior laryngeal vein, and the nerve has got some relationship. 70% superior, you will get superior laryngeal vein, then superior laryngeal artery, and then nerve in paraglottic space. Now, cricoarytenoid unit. So we all know cricoarytenoid unit, what it is, how it works. But the important point is, this is the paramount of all functional aspect of the larynx, and it is mandatory to preserve at least one functional cricoarytenoid unit in all conservative laryngectomies. Now, location and landmarks. So this is a picture of thyroid cartilage. Anterior commissure lies between thyroid notch and inferior thyroid border and somewhere midway in between. So about hypopharynx, just I am taking quick look. So it has got three segments: posterior pharyngeal wall, pyriform sinus, and post-cricoid area. So pyriform sinus, we all know about anatomy, basic anatomy, but the important is pyriform fossa is in communication with paraglottic space. So any lesion in the pyriform sinus can invade through paraglottic space and affect the mobility. Now, post-cricoid region. Post-cricoid region is a region behind the larynx. It is common for carcinoma in females for Plummer-Wilson syndrome, and this area is difficult in routine laryngoscopy examination. So, thank you so much. This is all from my side.